Hi everyone, we will go ahead and get started. So today's presentation is going to be on team-based care program prioritization, and we're very lucky to have Alicia Majer here to present us. She is a healthcare operations and population health leader with deep statewide experience supporting independent and employed physician organizations and multi-payer value-based care programs across Michigan. She's led practice transformation, care management infrastructure development, and performance improvement initiatives with networks ranging from independent primary care practices to large multi-specialty physician organizations and ACOs. In her private role or prior role, with Huron Valley Physician Association, Medical Advantage Group, and CareBridge, Alicia worked with physician offices and leadership teams to improve quality, utilization, and financial performance under programs such as BCBSM PGIP, Medicare ACO models, and Michigan's primary care transformation initiatives. While at HVPA, she was directly involved in the rebuild of Health Focus to support the HVPA clinics and pay for performance programs. Currently, Alicia serves as the Director of Care Management and Population Health for the Academic Medical Center at the University of Michigan Medical Group, where she currently oversees multidisciplinary care management and population health programs, aligning operations, analytics, and clinical teams to improve outcomes and support value-based care performance. With that, Alicia, if you want to share your slides, I'll go over the CME ones to start and then hand it off to you.
Thank you. Make sure it's moving. There.
Perfect. Yep. So just for everyone's awareness, this is the information on the CE credits. So we're able to give credit for CME, for nursing CE, for dietetic CPEU, and for pharmacy CE, as well as for social work continuing education. This will be 1 credit hour for each of those. You can, if you want to get the evaluation early, text this code to the number on the screen here. If you do not text the code to the number on the screen, you're still going to get the evaluation added for you. It just takes a little bit longer and will show up sometime next week instead of showing up immediately. But if you don't text the number, you're still going to be able to complete the evaluation. So don't worry, it'll just be a little bit longer before it's added to your profile. Okay, next slide.
Whatever it is, it's making me click down there.
Weird. Okay. Great. Thanks, Lucia. I will hand it over to you.
Great. Thank you so much, Jackie. And thank you to everyone. And please feel free to jump in with questions or discuss. While I am giving a presentation, I prefer it to be a little bit more open like that. Plus, I recognize a lot of the names on this Zoom, and know that you all have a lot of knowledge in this space as well, and a lot of interesting things to share. So the objectives for this session are that participants will be able to describe the challenges of managing competing priorities across payer requirements, organizational leadership goals, and day-to-day clinic operations. We'll discuss approaches for aligning diverse project demands into cohesive, usable workflows that enhance care delivery and support better patient outcomes. And then finally, we'll identify practical ways team-based care can support quality improvement without adding unnecessary burden to clinicians and staff. So why does this matter? Primary care teams, specialty care teams as well, but in general, primary care teams have always been tasked with trying to accomplish so many different overlapping programs that all have some element of the same expectation. And we see this in our quality measures where payers have very similar quality metrics, but they kind of on the fringes start to diverge. And this leads into things like our CQI goals, where it's the same, just slightly different, but maybe helping out on a couple of different layers. Our own internal organizational priorities. I'm now at a system, but even in the independent world, different organizations, different clinics, each clinic was its own essentially system. And you had to understand what was the important thing for that clinic to be able to accomplish. Access and patient experience demands. So there's only so much you can do with patients and getting them in if you don't have the space to bring them in, or you don't have the capacity. Staffing constraints is right there up there. day-to-day clinic operations. Today somebody is sick, they can't get this piece of work done, which makes everybody else have to take it on, which or maybe it just doesn't get done at all. Provider and staff burnout, and then patient outcomes and equity goals alongside of that. These are a whole slew of things that we are trying as leaders in our various organizations to balance and understand. And that can make it difficult to prioritize and align all of these different projects to work together. And that's really, the reality of the situation, and it becomes initiative overload. So you have every time you go to a meeting, you get another quality measure with a different perhaps timeline. This one is maybe calendar year, but for those of you who work on a non-calendar fiscal year, you're thinking about that differently, and different stakeholders are asking for different views of the same information or maybe slightly different information. And each time you're kind of putting on another workload, sort of creating this big layer cake. Um, and, working with staff who are experiencing this, but trying to do their job in that environment. And it just becomes a difficult challenge. So, what can we do for that? Um, One of the first things that I try to do is figure out the source. So, where are my sources of different things, and how do I bucket my communication strategies so that people are aware of what everything takes to get that information back to them, as well as what my limitations are and where I can impact. So, for example, for payers, they're commonly asking for us to improve our quality metrics and close care gaps, as well as submit data. So, what does this mean? This means that at the clinic level, we have to have a really good way for tracking that data, for outreaching specific patients, documenting, reporting, and honestly, there's a financial accountability piece there where we have to understand how much money is linked with these activities as a prioritization aspect, but also just as an understanding of, is the effort that I'm putting in worth it for what I'm getting back, knowing that we can't necessarily do everything. From a system or like a PO leadership situation, you're looking at, how am I meeting or improving the performance standards? A lot of POs have they have like a scorecard that outlines what are the priorities for this year. What didn't we do well on last year? What processes are we all trying to align on together to standardize care and have the experience be continuous, maybe between primary care and specialty or just for a disease group? And then there's the contractual agreements that you have where each contract might have a different piece that sort of shifts the priority within that contract or kind of overall, so that the physician organization or the system is looking at something that is different than a specific payer or your clinic operations might look at. And at the clinic level, you're seeing that within dashboards, operational changes or operational, like if you have a common system or an EHR or registry, you're looking at different changes that are coming through there and how those are prioritized, as well as the financial accountability from the system. So I mentioned the scorecard. Sometimes POs pay along a scorecard. Sometimes it matters on how your revenue is acknowledged at a system level. So all of these things are kind of aligning in together. On the clinic operations side, you it's sort of a very day-to-day workload. Like, what is your access for today? What staffing do you have today to support that? Who are able to engage in some of these not extra but maybe non-common workflows? And then the sustainability there, like, are we maintaining our billing? Are we maintaining our core operations in a way that sustains the clinic still? And so it's the sort of base or core processes of scheduling, rooming, workflows, and patient flow. And then the next bucket is patients and families. So patient satisfaction is one of those metrics that's both elusive but really important. and how do you connect in with your patients and make sure that you're providing care in a way that that makes them happy and makes them feel like they're being cared for, which is often difficult to do because it's difficult to please all people. Um, but timely and coordinated care, good quality that they can expect, and as low cost as possible. And a lot of that means communication, ways to build trust and shared decision making, which leads into your staff and your care teams. So, what do you have in terms of clear roles and manageable workloads and support? And that's a really difficult thing to manage across all of these different pieces, but it ends up being team based care, huddles, and escalation pathways. And the reason why it's important to figure out these sources and these buckets is that one of the ways that I recommend bucketing your work is kind of along buckets like this so that you have a way of organizing your own thoughts and aren't sort of dragged into a million different pieces, but kind of understand what lane am I thinking of, what lane am I working in, and that kind of makes the rest of the pieces fall into place. And then alongside of that, the idea of invisible demands and making those things visible when you're communicating back up through payers or system leadership or around clinical operations back to patients and families and within care teams, unless the invisible work is part of the understanding and part of the workflow and part of the accountability, that invisible work begins to eat away at what you can actually accomplish. So that leads me into what sort of I mentally had to do a shift. And this shift was from individual workflows into buckets of workflows or projects into workflows. So you think, kind of looking at this diagram here, if you're looking at all of the different things that we have to do, MCT2D, inhale, my mind, quality and HEDIS, emergency department follow-ups, transitions of care, chronic disease management, just to name a few. And I know that there are tons more across there. Um, if you think of them each as their own project with their own sort of silo of work, you lose the ability to have commonality and you lose the ability to think of the workflow surrounding it as part of the group rather than an individual piece. So the idea of moving from projects to workflows is saying instead of every single individual program having its own um, space, you think of it in terms of the major workflow or what people are doing when they're trying to accomplish that. So patient visits, how are we engaging around patient visits and knowing which patient visits are appropriate for that person in their situation? What documentation do we have to do? Do we need admin time for this or what's going on with that? What kind of clinical communication has to be happening across different team members and how do we assure that billing is happening in a way that supports all of these processes? And that is a really difficult switch and it's not clean. So you know, there's always a check back where you have to say, okay, for each of these projects, do these processes make sense and are they meeting the goals of those projects? But when you're thinking through implementation, it's sort of like a feeder into these major core workflows versus creating, the layer cake that inevitably like sags and falls over. So some examples of this are in our team-based care. So we have provider delivered care management. We have all of these other ones, MCT2D, inhale, my mind, quality and HEDIS, ED follow-up, but how does team-based care support all of those things? And it spans a lot of that. It spans the quality and utilization measures when you think of who's going to be doing follow-up. It spans the billing and the reporting piece when you think of documentation and not just documentation in the chart for supplemental data, et cetera, but also documentation for billing. When you think of what is implemented into the CQIs, when you think of chronic disease management and transitions of care, you can kind of bundle it into an idea of team-based care. And so the kind of takeaway there is that creating workflows around function rather than the project means that people don't have to think through and know each and every single project as a standalone when they're trying to provide care for patients that might be involved in a lot of different things, but rather they have their workflow of, how do I document and what gets triggered by this patient? What do I need to communicate and what is triggered by this patient and what do I need to do for billing? I might pause there for a second and just do a check in to see if what I'm saying resonates at all with people on the call. And if you have any thoughts or any experiences that are similar to mine with this kind of project to workflow shift. Hopefully, I'm not the only one who sees this, but maybe as we move forward, there will be um, more connections into that idea. I see one person saying yes, agree with your thoughts. Thank you. And then I think they'll get back to you on the 5-digit code. So part of this is also what I call choose your own adventure. It's hard to know what bundle works best for every single workflow or like what bundle works best for the different projects, but um, I tend to go back to good old current state process mapping and I bundle those things in my mind into two different categories. The first one is the patient journey. Um, so thinking through sort of the trigger or when do we need to know about what's going on with this patient so that we engage, the kind of pivot on the workflow around that project. And the thing that's really important there is even just having those core workflows documented and clear so that you can kind of point to the spot where it needs to adjust slightly and or be where it needs to shift so that you know when to engage. So for example, you have your patient calling in maybe to schedule their annual wellness visit. At that time, do we know what other things they might be eligible for when they come in for the annual wellness visit, or if they want to add something on? Is that patient eligible for MCT2D? Have they had their inhaler education for inhale? What are we doing? Have they had their depression screening for my mind? What other gaps in care might they need? And so trying to move some of those things into like pre-visit planning as to what we can, engage that patient on when we have them. And then similar work bundles. And this is where the idea of process and muscle memory comes into place. I find that just personally, I'm able to take on more work if I can put a lot of things into the I don't have to put too much thought in it category. Like this is just how my like easy workflow happens. And that's with that comes with standardization and automation. So whatever we can do to take out the decision points for people, but have it be prompted or visible, makes things a lot easier. And a lot of times billing workflows can be great for that because you can kind of push things forward. And I see some comments as I'm pausing here to just check in with everyone of, I have a terrible memory and need it as one thing. Yes, that is exactly how I am. You can't remember everything. You need to sort of have it be the clear next step in your process. And unifying standards is exactly spot on. So these are the kind of ways I start to approach when I'm getting overwhelmed with all of these different projects or when a project comes in. I think like, where do I need to intervene to make this just part of my life versus another sort of thorn. So that's where like these questions I think are really helpful. And I try to to use them as like the triggering place for where do I get started. So one is when does the workflow start? So if you're thinking about, like, let's just say like a transitions of care patient, when does that workflow start in your organization? In some organizations, it starts at admission. In some organizations, it starts, sorry, upon discharge. On some with some organizations, it starts with pending discharge so that you can start some of the discharge processes. So knowing when the workflow starts can help you know, like, where do I need to start my understanding, and where do I need to make that piece of the workflow easy so that it's not missed. And then who's owning each step, obvious one, but sometimes that becomes a challenge, and you have people who it makes sense with in two areas, and sometimes the owner is like the 20% difference on like a standardized workflow that can go across many different places. And that's where documenting in maybe each different clinic becomes a little bit different, just because the different resources that are available. um, the documentation tools, I find that this is the most important, to standardize as much as possible and to share across standardization. Partly because if you can't track what's being done, the standardization helps tracking for what's being done, especially if you're on a tool like Epic or like Athena, where you can say and pull up data on the different documentation tools that are created. And then that helps with an escalation point of, if something isn't working, do you know how to ask a question around that so that it becomes a problem solving situation versus like something that's just not working for a very long time. For example, we had I'll give you an Inhale example. I know this is an MCT2D crowd, but maybe there's overlap. Inhale is one of the other clinical quality initiatives, or CQIs, around asthma and COPD. And we realized that our billing code that we use for that group um, to track our asthma education wasn't working in the way that we thought it was. It wasn't actually sending anything to Blue Cross. So there's those pieces of, how do you find that before the whole year has passed and you realize that you haven't been communicating what you thought you were communicating. Also, oops, I changed this slide too quickly. Back up when staffing is short. So how are you organizing your team? We found that a lot of times we need like two people on critical processes at least, so that there's one person, there's two people who understand the process, even if it's not a like a full-time work. If you can share that thing, then you have that cross training, and processes can continue even when people are out unexpectedly. And then feedback. So checking in with the team on how all of those processes are working. So I I try to start with patient journey mapping, and this is a very basic patient journey map. I don't think any of this would be surprising to you, but this is where I find a lot of my quality issues start to bubble into. And for example, I'm always struggling in my clinics with pre-visit planning, whether it's happening or not. And so the ideal is, of course, that you have, registry review and care gap identification before people are coming in, that we know which initiatives they're part of, that their screening tools are completed, and that, maybe we're pending orders or referrals based on patient characteristics. But that isn't always happening. And that's that's where you start to get your opportunities and your triggers for when new projects are coming into play of, where would I ideally have this happen? And then the process improvement for the clinic is not necessarily like, oh, we have an MCT2D initiative that we have to do, unless that's the passion within the clinic. But if you're in a situation where your clinic is like, not one more thing, we're not doing one more thing, then it's a conversation around, okay, here's our common process. How can we make it easier on everybody? We're going to address some of this, process burnout by trying this, and then you kind of insert your process requirements into that piece rather than kind of introducing a whole new initiative. This is an example I find that pre-visit planning and trying to do things as much upfront and automating that is one of the things that helps us the most. Apologies, I forgot to close out my teams. So for example, one of the palliative care things that we're trying to do is look for patients who are high risk in some of our clinics and pend an order for a palliative care education or other visit, um, so that when that patient comes in, the provider can decide at that time whether they want to sign the order and make that referral happen. Um, Making it sort of having that trigger be very clear for the provider that this is a patient who could benefit from that. And the same idea can be done with other kinds of projects where you're trying to like move people into different support structures or different programs, but you don't need the people who are trying to focus on a patient and their problems having to make that decision at that time. We do the same thing with our diagnosis documentation where we bring it up front into the beginning and we sort of lay it out there for our providers to say, okay, here's the all the diagnoses that haven't been touched this year. Are there any that you want to diagnose this time or no? And it helps with that. Do the do the groups on this Zoom, do you all have that same idea of pre-visit planning, or is that something that is new around here or that you haven't really engaged in yet? Some some chats I see yes, and then like we do, but it's spotty. We do when there's time, right? I think the challenge is getting it to be done consistently as well. Um, and that's I think where the benefit of having projects shifted into processes like this and workflows becomes better, because then as you have a lot of projects that rely on this workflow to happen, it starts to create the shared motivation to actually get it to happen and become a stronger process within the clinic. And then also it creates the measurement tool because you tend to be able to watch like were these things happening, and it's the sort of tracking part of your process. Yeah, I see. It took a few years to get good at it. Exactly, encouraging practices, but it's challenging. And morning huddles are really helpful. I completely agree with that. And I found inconsistent desire to do morning huddles, but when people do have a morning huddle, um, it becomes like the thing that they really want to do all the time. Yeah. And I see pre-visit planning is crucial. My day is different without it being done. Exactly. Like these, um, being able to sort of align things into these different buckets and convince the clinics of the importance is important. And that leads me into the idea of core workflows. So when I'm trying to think of like what mindset do I have to keep in, or what is the sort of big change for people as I'm implementing a new program? Is it the patient visit part, like that pre-visit planning? Is it the documentation part? Is it billing, or is it clinical communication? And I think the huddles comment from the chat really talks about the importance of clinical communication. And I struggle, like this is maybe like the biggest challenge that we have in our clinics of, um, and I consider it one of those situations of like cutting off your nose to spite your face. If you don't have that time to discuss, then you lose the coordination that you need to have your day be really efficient. And I don't know if you all, if anybody who, or maybe the person who talked about their morning huddles, if you have a success story for how you convinced your team to do that, I feel like it would be really helpful for the group and me, because I know that this is one of those things that works in the places where it works, but I haven't been able to make it a consistent piece across. Happy to see that sharing, or if you have any comments, happy to hear them. And I guess the other thing I'll say is that this is also the choose your own adventure part, because you kind of have to gauge where in each clinic or each area where is the interest in working and start there. Because if you start in an area where people aren't interested in working or don't have some sort of predisposition to improve, you start to butt your head up against all the wall of all the impossibilities. Oh, I see. I see the example in the chat of when we routinely made it to lunch and decent end of day time, it changed attitudes. No kidding. Um, and I see set days and first thing in the morning. This is something the clinic has been doing before I arrived. Yeah, like those kinds of discussion points are just really important. So I forgot I had the slide on specifically huddles now that we've been talking about it. But I do want to point out that uh, when you do get to a routine, there are different kinds of huddles or meetings. And so you have your daily huddle or like your set time huddle where you're talking through like what needs to be done today. And that's the opportunity or trigger point where you can insert your project process into the overall workflow. Um, but then you kind of do need this other quality focused huddle where you're talking about your measure performance or your workflow barriers, PDCA or PDSA updates, success stories, and upcoming changes. And I think there needs to be a difference between those and an amount of time difference. So you expect your daily huddle to be really short, but your quality huddle needs a little bit more time. And both of them need to be routine so that you can follow up on whatever decisions you made. It's very interesting to me the capacity of what you can accomplish in 30 minutes for with quality huddles. And I like to call them a huddle because when you talk about adding on meetings, people have that immediately like gut reflex of not me. You can have your meeting. I don't need to be part of that. But when you talk about needing to talk about something for 10 to 15 minutes or kind of brainstorm around a specific project, it becomes a little easier. And I see the comment that says the office reads through and shares satisfaction surveys also once a month during the huddle. Yeah, so if you're able to allocate part of your huddles to some of these um, important pieces and it's part of your routine, that's when it gets done. If it's not part of the routine, if it's like an extra thing that has to be layered on top, that's when it stops being something that is done consistently and is only done when people remember or feel like they have extra time. And I think that's the difference between like a project, which feels like you can only do when you have the time, and a consistent workflow that uh, is the day. It's the normal day. So when when you all are looking, I'd be curious to know how you kind of organize your thoughts. But the way that I try to bundle things that are outside of the patient journey is into sort of like-minded workflows, and not everything fits nicely into the patient journey. So for example, care gap closures is one of those things that is both in the patient journey because you have your annual wellness visits, you're completing it, but you still need a care gap closure process that is outside of the patient visit because you don't get everything done sometimes in a patient visit, or patients don't come in, or we have to find them. They're not called care gaps, because they're on purpose care gaps. They're care gaps because there's a extra piece of the puzzle that we have to do to get people in. And so I consider a lot of those preventive care gap closures in their own kind of bucket for work. And there's a lot of different ways that like we've approached doing this. So for example, now that the way that we do it is we have like a weighted care gap report, we call it. And for the first half of the year, we call patients and try to bring them in based on how many care gaps they need and how many we can close by getting that patient back in. And we all know that there's some care gaps that are going to help with some of the other things. So if we can get people in for their annual wellness visit, they're likely going to get some of the cancer screenings and get those addressed during that annual wellness visit, or for the well child visits, things like that. If we can get them in, they're likely going to address immunizations at that time. And so we gave those things a higher weight. And then we also have some of our at-risk populations, and we give them a higher weight as well, so that they can bubble up and maybe get more help in addressing their preventive care needs. And so our teams kind of prioritize based on those things, and they use the first half of the year to call out just based on what gaps there are. And that gives enough time for some of our payer reporting to catch up and for us to understand, how are we doing overall. And then in the second half of the year, we we are a little bit more targeted, looking at, okay, so for our biggest payers and our biggest metrics, or for like the metrics with the most opportunity from a financial perspective, how do we shift our outreach to be very specific? And when we're calling people, we're not just closing the one outreach, we're closing all, sorry, not just closing the one care gap, we're looking at everything that they have. But the way that we're approaching those calls changes. And so we kind of have that bundled all in one place. And it's not just, what is the workflow for colorectal cancer screening or breast cancer screening or cervical cancer screening. And each does have a way that we approach them, but it's sort of bundled into this, preventive care gap closure grouping. Same thing is true for like chronic disease management. So I'll just say like kidney health is one that's new. And so we've had to think through what is the process for kidney health. And we've done a lot of work on that one for education, but also, how do we use technology to remind people of what labs they might need so that they can get those labs done before the end of the year. And so a lot of communication to the patients electronically and pending orders again. For diabetes and hypertension, we've been trying to be very clear on our well, in Epic, it's called our practice advisory. It's basically like the pop-up that happens when somebody has diabetes. What are the options that you have? Does this person need to see a pharmacist or a dietitian or a nurse? Same thing for hypertension. How are we managing that going forward? And what are your options? And making it clear in that trigger. And then finally, transitions of care. It's generally for us the same team doing emergency department follow-up and hospital discharge follow-up. And then we have a complex care management team that is able to take referrals, but is mostly doing proactive care based on what our risk score is in Epic that we've like slightly modified. But the idea being, how are we engaging with our high-risk patients? Just for those on the Zoom, are these bundles things that you've organized as well? Do you have like a different way of looking at your sort of outside the normal patient journey process? I see. Curious if how pre-diabetes is triggered an intervention. Yeah, that's a very good point. So I kind of lump that into diabetes control. We have a dietitian who we have a couple of dietitians in our primary care teams, and they have a lot of referrals for mostly pre-diabetes. And they start out with like a group visit, just sort of talking about, do you know the things that you should know around pre-diabetes and what's prevention and how do you sort of have manage your lifestyle for that. And from there, they can support the patient one-on-one after that group visit. And it's generally, we have both a registry that can look at those patients as well as like part of the OPA that we talked about. It's an opportunity to say like, go into this class. And then I appreciate the end of life discussion. Thank you so much for bringing that up. I agree. Bundle 3 is a really good time for that. That's actually one of the sort of process insertions that we're thinking through of at hospital discharge. And, ideally, if we had more inpatient connection, we could start this on the inpatient side. But in hospital discharge, are we identifying those patients who do or do not have a durable power of attorney and do or do not, or could or could not fit from either a palliative care or hospice referral? Excuse me. And that's a great time for that. And I see another comment in here. They feel like their process is so kind of aligned to this thing, but their process is good for some things, and they have systems preventive and chronic disease management, but there's room for improvement and a better team-based care approach. They still place a lot of focus on the clinicians rather than the whole team involved in the patient's care. I think that's a really good point, and that's where let me remember what my next slide is because you might have just given a great segue into the next slide, and you did. So I think that that's where sort of clarifying who do we want involved in that initial trigger and how much is it the role of the kind of physicians and APPs to trigger these things, or can it be brought into that sort of pre-visit planning, or can it be brought into a standing order of some sort that allows those care team members to engage without needing there to be a decision on the part of the clinician? And that sort of crosses both like the patient journey mapping as well as that sort of overall quality and trust within your team processes. So these are just some examples for um, for like what a task might be and where the team member might be. But when you're thinking of team-based care, outreach lists or referral follow-ups or the quality piece. Um, One of the things that we try to do, and especially this is with our collaborative care teams, is identify those patients proactively and reach back out to see if the provider would want to engage. So we really rely on registries and um, reporting to say, okay, here's all of your patients in patient X, or sorry, physician X. Here's the patients who we see have, for example, with collaborative care, a PHQ-9 greater than 10, but not like a real, and would be appropriate for our support. Do you want to enroll them in this? And then it sort of takes some of the onus off of the physician and kind of identifying up front, like who are we tasking with the responsibility of identifying appropriate patients for this work and where they can be engaged is one of the ways that you can help with that burden on the clinician of always being the one to decide who gets what and the responsibility there. Another example of kind of taking the burden off of the clinicians that I have from our workflows is our social determinants of health workflow. The way that we did that one is we have a like 30 days before the visit, we send out a questionnaire, and can be a visit. Now we made it kind of anywhere in our ambulatory care system. So if you haven't been screened in a year, we want you to get screened no matter what visit is coming up with your provider. Maybe it's diabetes, maybe it's surgery, maybe it's what have you, but we want everybody to be screened. And so 30 days prior to the visit, we send it out and we try and remind people to fill out that questionnaire. And then the positive screens for people who also want help are sent to a common in basket. And that common in basket is monitored by a centralized team who is more familiar with the support in the area and more familiar with the resources than maybe our common front desk teams or what have you. And so they feel more empowered to answer, what could happen. And they try to get those. The reason why we do it 30 days before is so that we have time to answer those patients and we have time to potentially get them the resources prior to the visit in case it's like transportation or something where they really needed that resource in order to get to the visit in question. And that was a change from historically where we relied on the physician to review the SDOH or social determinants of health or drivers of health outcomes and positives and ask their team to then get connections in. And it was a mismatch of what our providers felt comfortable with and where the sort of subject matter expertise was on our team. So thank you for bringing that up of the focus of clinicians and the whole team. I included this because I think one of the downfalls of bundling processes and thinking through all of these different processes is sometimes you can get to lots and lots of different um, sort of trial and error processes that just go on forever because they work for a sliver and you don't want to stop providing that care, but then now you have a lot of different things going on at the same time. And this is one of the places where my team is currently working to condense into less processes, into more common processes across, because it's just not it. You never know, as a clinician, you're never going to know what support your patient is going to get because you don't know where they're coming from, or are they an ACO member, or are they a value-based, a risk-based contract member, or what's going on. It makes it really variable what care people are getting and what support they're getting, when really it'd be better if we were more consistent across the board, and that would help our providers know what they had to do versus what they were relying on a different care team member to do. So I don't expect anyone to sort of look at this and understand, but you can see that um, all of these workflows, none of these things are simple. And even when you try to bundle things like a transitions of care workflow, it can quickly get very complicated. And but that's a almost like a good thing also, that you wouldn't have identified the complexity unless you documented it and seen where you could start to compress and decrease the complication of processes for your teams and for your own workflows. Do other people experience this sort of or explosion of pilots and different processes around the same thing, where you find that you have 10, I don't even know how many we have here, 10, 12 different ways of starting to approach the same thing, and you just need it to be more standardized? Yep. Yes. And I think I saw even earlier in the chat that, standard workflows are incredibly important. So you all are not alone, and I'm not coming from a place of, yes, I've got this all figured out. I'm coming from a place of, here are the things that I've found decrease the complexity so that I can work on things and start to, improve our metrics and take better care of our patients. And that leads into the idea of, you have these current states that's really important to process map out, but then, how do you insert your project, and how do you have continuous improvement? And so initially, when I'm looking at initial alignment of a new workflow or a new project, I sort of take inventory of, what initiatives do I already have, and what things are being worked on right now. Are my processes correct? Do I know still what's happening, even though, like, I might think that I do, I might not. Um, there's always new surprises. And then I think through, okay, so like, what teams have to be engaged? Is this a billing thing? Is this a pre-visit planning thing? Is this, where am I going to start? What bundles am I going to be impacting? What core workflows do I have to adjust for this? And then really importantly, how do I know whether or not my workflow is working, and if it needs adjusting? And like, that monitor and adapt cannot be undersold, because without it, you just have no idea if you're even still working on things that you thought you were working on. And so as you kind of flow into continuous improvement, the mapping, workflow alignment, and monitor and adapt become what needs to be focused on versus all of those other pieces. And the more that you can get into the continuous improvement and sort of insert new projects into this part of continuous improvement, that's where you find that you don't have to have all of these different layers and memory pieces, but really just, the core workflow that you are working on and modifying all the time. And that, whenever I see this table, I don't know if you guys have the same reaction to this table. I have both like gosh, I really need to earn as much of the money of this as I possibly can so that I can fund my initiatives reaction, as well as, how am I going to do all of these initiatives at the same time? reaction. And this is sort of emphasizing, what do we do in primary care and how do we engage around all of this? And this is where I think that bundling idea from a couple of slides ago starts to become really helpful. Like all of these CQIs, they're very, very different, but they have a lot of similar elements that you can build on and sort of use into those core journey mappings that we talked about. And these things are going to promote all of the clinical quality performance and benchmark and utilization benchmark performances. And then when you think of team-based care and care management, you sort of organize your ideas into, okay, my core is maybe provider delivered care management. How does that support any of these other things? And then what is the relationship or how do I engage around collaborative care and PDCM and these other pieces? So I try to kind of connect in um, which which workflows I need to work on that will hit uh, the most outcomes and the most VBR opportunities at the end of the day. And I think in a couple of slides, I have a way of prioritizing that. So I'm going to touch back on that then. But I just wanted to kind of bring this up again because this is, I think, an old one. This was for calendar year 2024, and they're going to release the way that things are changing now for per member per month. But uh, this is sort of like the start of your bundle and like where can you work on. And it doesn't stop in primary care, it's also in specialty care for those of you who have specialty care areas as well, where the VBR is linked to a whole bunch of different pieces and it's all connected, right? So your the specialist population-based VBR is looking at quality as well as cost on our primary care attributed lives. And then they have the CQIs, which are, common to what we're talking about here as well. And then the specific practice level engagements. So there's just, if you look at all of these things individually, it does just become a little bit overwhelming. But um, when you start to prioritize them into bundles and think it through, or like sort of organize it, it becomes less overwhelming. So, for example, for MCT2D, you kind of look at the workflow modifications with the list that I had earlier of like, where's the trigger, right? When does the workflow start? So how do you get the referrals in for patients? So you need both the sort of common part of the patient journey, like how do we connect patients into MCT2D during the patient journey, and then you need the proactive list of patients who weren't connected in for whatever reason, and how do we get those patients engaged? Talking about the people on the teams, who's the owner of each step. Clear tools, where is it documented, escalation, feedback, and etc. And I see I have been talking too long on each of these slides. So let me continue in and just give an example of some of workflow modifications that we've done. So in our PharmD and primary care physician billing workflow is here. Let me see. This is with only a few minutes. Let me get to the part and our PCP workflow. But we used to have this really long DME ordering process that we had to fill out here. And in the future one, it became a much simpler way of doing things that is more successful and more clear as to what you need. So this is sort of that documentation piece of how are you documenting during each visit and how do you make that both clear and more simple, and everybody will then do it. So the dot phrase continued. Also the feedback, so order bounce back, if you don't need to do a piece or you did it wrong, how do you know? And then reminders, like how is your physician supposed to document for various things? So this is like the documentation and workflow insertion that our teams have done for MCT2D. And that gets me into the idea of data. So one of the things that we've talked about a lot is the workflow and managing the workflow. But all of this is related to are you able to manage your processes and know what's going on with processes? And while a lot of our focus is on outcomes, if you don't understand how your process is working, then your outcomes will suffer. And the first thing that people ask about outcomes is why aren't we achieving it? And then it goes right back into process metrics like are the right patients getting the right intervention? Um, do you have checkpoints to know that is the documentation that you wanted to happen happening at the encounters that you wanted to happen? How are your teams handling the workload? And are you able to understand when there is a process opportunity in there? And then finally, taking all of this work and translating it up, down, and across, which as clinic managers, this is like the area that you're stuck in. And this is also where documentation being able to track is really important because as you have to communicate back up to the peers and CQI goals and sort of outside of the organization, you need to be able to communicate back up there. You need to be able to tell your physician organization leadership or your clinic leadership, what's going on that is allowing you or not allowing you to achieve these goals. And then finally, you have to be able to translate for your staff. What are we going to do this year and how are we working on it? And, you can't do everything. And so this is the sort of key slide also of prioritization. And I'm sure that many of you have seen this impact effort table before. But I find myself using things like this a lot to just decide, what can I do? And how do I bundle and which bundle is going to take priority? And what things can are in the like right now versus like the build layer of work. And the way that I prioritize are based on financial, leadership, interest, and motivation, data availability, and staffing capacity. If I can't track and document on something, then it's going to go into this sort of low impact and low effort, or low impact and high effort if you can't document and you can't understand it because you're never going to be able to redesign it without having that data. So kind of understanding like what are you working with and where can you make improvements, and then talking about those improvements everywhere are kind of the main piece for kind of prioritizing and choosing which part of your bundle are you going to work on. So, oops, sorry. In conclusion, then there are like several key points that I just wanted to discuss and relay here that the competing demands are real, but there's a lot of common workflows across these initiatives. And visibility is where alignment starts. And this starts with, what are the current state processes? What are we doing? Where's the hidden work? And that does lead into team-based care and how can you align that work into the right role so that you're not leaving everything to the clinician, so that you're not leaving everything to a front desk person or vice versa, but they understand and feel that they're able to complete their roles, and you're having everybody work to the top of their license. Standard work is key to aligning all of these different projects into a usable workflow, which then improves everybody's performance and allows for performance measurement and performance improvement. And then as clinic managers and leaders, you are the essential translator across all of this and sort of the crux of, what payers are asking for, what physician organization leadership and system leadership are asking for, and what the front lines need in order to implement all of this work. So with that, I was hoping to leave a few minutes for just discussion or comments or what you all see as you're working in your clinics and how you're organizing all of these different fields of work into a usable use approach for your teams and communicating that back up to your leaders. And I can stop sharing if we want to kind of talk or chat. Oh, it's also 1 o'clock, so we're at the end.